Hi, everyone, and thank you for joining us for the UW Fred Hutch CFAR and Public Health Seattle and King County LunchbBox talk. Today, we're going to be welcoming Dr. Chase Cannon to talk about his home-based PrEP monitoring work. Dr. Cannon is an acting assistant professor at the University of Washington Division of Allergy and Infectious Disease in the Department of Medicine, and also the deputy medical director of our sexual health clinic. Chase, if you would like to add to your intro, feel free, but I'm just going to turn it over to you and you can get started.
Yes, thank you, Roxanne. No need to add anything else. I think that's fine. People know who I am, and I just want to get started so we can have time for questions because there's a lot to discuss on this topic. So today I'll be talking a bit about how there are many considerations to take in mind when you're implementing a home-based monitoring option. So specifically for PrEP, but I think this could be applied to different settings where people are wanting to expand STI testing and HIV testing in the community. So talk a little bit about some challenges and next steps. And as Roxanne mentioned, I will talk some about my research, but I think this is more of a sort of broad kind of logistic overview. So let's get started. Feel free to put questions in the chat, and I can try to address some of those if they're clarification questions as we go through, but otherwise we'll have some time at the end. Okay, so just one disclosure that I will discuss as we're going in. So as an outline, I'll talk a little bit about sort of the intersecting HIV and STI epidemics and how those have led to several prevention needs and where alternative models for PrEP monitoring and care fit into those needs. Again, as I mentioned, talk about some implementation considerations for remote or home-based PrEP, and talk some about our example here, what we've done, where there are some gaps, and some future directions with time for questions and answers. So many of you are very, very familiar with this. I don't need to belabor this, but we really have sort of a tale of two epidemics where on one hand, we have rising levels of STIs in the United States and here in King County. For certain populations, like men who have sex with men, some of those numbers are actually sort of plateaued. But in other populations, such as women and men who have sex with women, we're really seeing dramatic increases in things like syphilis. And some of those are leading to cases of syphilis in newborns or congenital syphilis. On the other hand, on the right side, we have HIV diagnoses. So for 2019, which is sort of the last year, we kind of have complete data that we can trust, so to speak, before the pandemic really threw everything off. We have really been seeing decreases in most areas for the number of new diagnoses, but still a considerable amount. So 37,000 or so in that year. And that really has led to us to kind of think about how we can get those numbers down even more. Although we're seeing decreases, we want that to go down even more. So what are the prevention strategies we have for STIs? These are sort of tried and true. A lot of these have been going on for decades, and we're all very familiar with them. Barrier methods, variable uptake. Not everyone wants to use those, but they can be effective as a part of a comprehensive prevention strategy. Of course, general education, counseling regarding safer sex practices, and how to change your life around sex, I think is a good thing to know, but is not always going to drive down the rates of STIs alone. Of course, abstinence, non-partnered sex, that is something that is discussed, but not for everyone. Vaccines, we only have for certain pathogens, so HPV, hepatitis B. There is some discussion about the use of meningococcal B vaccine for gonorrhea incidents. And then we have other biomedical interventions that many of you are familiar with, some microbicides that are mostly used in other countries, and then doxy-PEP. So overall, the CDC has kind of said, we are taking this approach to talk about STIs, test for STIs, and then treat. For the HIV prevention side of things, all of you, I think, are probably familiar with the EHE initiative, which has these 4 pillars here to diagnose, treat, prevent, and respond quickly to outbreaks with the overall goal of reducing HIV diagnoses by 90% at 10 years. But really, I think sort of for the focus of this talk, we're going to talk about the prevention pillar. And when we combine everything we talked about for STIs and also for HIV testing, I think that sort of is packaged up nicely in PrEP care. And so all roads lead to PrEP. That's what I'm going to focus on for the remainder of this talk. So what are the challenges that we're up against? So we know that PrEP works. It has proven population level benefit, but uptake has not really been great. So coverage in the United States is pretty suboptimal. So estimates of from 2020 that about 25% of 1.2 million people with an indication for PrEP received a prescription. Here in King County, doing a little bit better than that 25%, where 40% of all men who have sex with men are estimated to be using PrEP. And then if we sort of restrict that to a group of men who have sex with men who are considered to be at even higher risk for HIV. So those are people who have 10 plus male sex partners and they're having anal sex using meth. They have a history of recent gonorrhea or chlamydia, or gonorrhea or syphilis diagnoses, or they're having condomless anal intercourse with any HIV positive partner or a partner with an unknown status. So when we restrict it to those people, that percentage goes up to 64%. But still what we're seeing locally and also nationally is a pretty significant disparity, both in terms of geography. So within our county, people who have access to services who are sort of in an urban area versus people who are in suburban and rural areas. And then also by race ethnicity, there are significant disparities. So some of these barriers that are identified in the literature are that, it's possible that providers don't still know about this, although we are over 10 years out from when HIV PrEP was really approved and sort of became more widespread in terms of knowledge in the community. There may be still people who don't know about it. There's still significant stigma, both on the provider side as well as for people in the community and users. There are still too few PrEP providers, so access is a major issue. Not as much in our county, in King County, but I think across the United States, and especially if you're getting into areas where there's more rural parts of the state. Yes, we have too few providers. In terms of inconvenience for follow-up, I think that is another big thing. So again, the rurality where if someone lives very far from a clinic, it's hard for them to get in to do their monitoring. They may not be able to take off of work, and so it can be inconvenient in that way. And then the burden of clinical monitoring could be significant for people who are working, an 8 to 5 or 8 to 6 job Monday through Friday. It's really hard to take off of work when you need that paycheck to go in every 3 months to have testing done. So I think we've all been encouraged to think outside of the box for PrEP because sort of what we've been doing has not worked the best. So this really started to come up during the COVID pandemic when CDC released some guidance to kind of have us think about how we can provide PrEP care when in the midst of, services being shut down, staffing decreases, that sort of thing. So in this Dear Colleague letter that was released in May 2020, they mentioned that it still is recommended for people to continue quarterly monitoring for patient safety, but that you could consider these 3 options. So the first is, of course, the most preferred option, lab-only visits, or you could do home specimen collection. So I'll talk a little bit about that. And then third would be home self-testing. So you may be asking yourself, what is the difference between those 2 options, the second and the third? So home testing refers to when a person self-collects their sample and they perform a test at the point of care and receive those results within a period of time, right where they're doing the collection of the sample. So an example of this might be the HIV OraQuick, which is the only FDA-approved test for HIV. Someone can go just buy that from a pharmacy, or they can order it online and get their result right then and there. So this is not ideal, obviously, for PrEP follow-up, because if someone is taking PrEP, we presume that they have a real risk for acquiring HIV, and they need to be using lab-based tests that have a shorter window period so that we can make sure that we're catching new diagnoses sooner rather than later. So we contrast that with home sampling, which is when someone again, collects a sample, but then they're sending that sample via mail to another laboratory that's doing analyses at a different place than where the sample was collected. And the person will receive the results later. So I sort of package this all kind of together, and I talk about this idea of home-based services, which I'll abbreviate here as HBS. And I may refer to this in another way throughout the talk as sort of alternative or remote care for PrEP. So that is sort of comprised of a few components. So one, telemedicine. So how is the person going to follow up with a provider, whoever that is, in case they need to have a medical consultation, in case they have symptoms that need to be addressed. Some of these things can be addressed over, say, telephone or by telehealth, like a Zoom call that we're doing right now. And some things, of course, need to be examined in person. So I think there's a little bit of a distinction there, but in general, we can offer some of these things remotely. Who's going to be then ordering the tests or the sampling? That has to be initiated by a provider. And then who's going to actually provide the PrEP after the results come back? Are they going to get it at home? Are they going to get it at a pharmacy? So there's a few different components here that sort of make up this package deal. So what I want to talk about next are sort of what are the options that exist. There are different models for alternative or home-based PrEP services, and I want to discuss a few of those now. So I will focus on three primary models that I know about, from the literature and have heard people discuss. We'll talk about each of these in a little bit more detail and look at a few examples. So the caveat, I think, is that some of these are kind of nested within dedicated PrEP programs, and then some provide STI testing that would be necessary for PrEP, but don't actually prescribe it. So you'll notice that there's a kind of common theme where you can kind of pick elements from some of these models to adapt for your own context if you would like. But I think the idea, at least from our perspective here in the sexual health clinic, is, we want this to be a comprehensive package where people are able to get essentially the same services they would be in the clinic, but from home. So let's talk a little bit about some of these models. So I'll start first with one that was published now about 3 or 4 years ago, PrEP at Home, that was through Emory University, where they brought in 55 people assigned male sex at birth who were on PrEP from different cities, San Francisco, St. Louis, and Boston. And they provided them with kits that included 3 site testings. So from the genitals, from the pharynx, and from the rectum for gonorrhea and chlamydia using nucleic acid amplification tests, which is our standard now for diagnosis for gonorrhea and chlamydia. And then they did finger stick blood sampling for a fixed titer RPR. So it was, a positive or negative at a certain RPR titer. They also did creatinine and then a second generation HIV test, which is different than what the PrEP guidelines now recommend. We want people to get a later generation test that has a shorter window period, especially if people are taking medication that could affect the accuracy of that test. So in this study, 93% of people completed this, and many of them said that they would choose the home-based sampling over the standard of care. 58% of people felt that pricking their finger was acceptable. And then when they asked about whether this option would increase PrEP persistence for people, about 40% of people said yes. So the next example is done in young men who have sex with men of color in San Francisco Bay Area. This is between 2016 and 2017, where these men were sent home kits for extragenital gonorrhea, chlamydia, and then they used Quest, so a third-party lab for the remainder of the PrEP lab tests. And then people were mailed out their PrEP medications every 3 months and had a clinician phone visit for follow-up. So this is, a little bit different, where you're kind of doing some testing in one place and then some testing in another place, and then the person who's following up is associated with the clinic and is sort of different than where the labs are being done. They found this was easy, convenient, confidential, but the time to PrEP was pretty long. So but the time that they got somebody enrolled and kind of gone through this process, and then they actually got started on PrEP in this study, was about 46 days, which is not ideal. And this was just an initiation pilot that they were doing. And so when people initiated on PrEP, they then had to be transferred to an outside provider to continue on PrEP. So for each of these models, I'll kind of at the end give you some benefits and drawbacks to these in case you're considering. So I would say for a clinic administered model, there is quite a bit of flexibility to adapt this to whatever your local context is. Again, you can kind of pick and choose which components work for you. You can incorporate this into a standing PrEP workflow for your clinic. And there's a menu of tests that you can use if you are working with an existing lab or contracting with a third-party partner that you trust. There is some control over the telehealth follow-up method, so a lot of different options for that. So, Zoom, you can use Doximity. There are other platforms that provide HIPAA-compliant sort of private interactions that you can have between whoever's in the clinic and then the person at home, or you can just use good old telephone as well. There are a few drawbacks. So, there is some startup time and you need personnel to kind of organize and implement this in your clinic. It may be challenging to get your administration or your clinic managers to buy into this. And I've heard that anecdotally from people around the country where they're really interested to get this going for their clinic, but they ask their directors and they kind of put a quash on that. So that can be a challenge. I think that's a whole other discussion to have. Curious to know how people have surmounted that. You will need to consider funding for the cost of the kits and the shipping. And so figuring out whether or not that can be built into like a general fund that you may have for your health department or for your clinic. And there are some regulatory limitations we'll discuss a little bit more for samples being self-collected outside of the clinical setting. So that is something to consider. Okay, so we'll move on next to the second model, which is pharmacy-based. So this example is from Iowa. There was an initial sort of pilot that they did back in 2017 as a telemedicine model where they used pharmacists to lead this. They got their labs from a public health clinic or another site. And they did note, at least in that initial pilot, it was hard when they contracted the labs out to another place that the self-collected extragenital screens were limited. And I think again, some of these issues we run into with outside labs is that they really don't want to veer outside of what their standard protocols are. And so although we're very familiar with doing self-collected extragenital gonorrhea chlamydia screening in our clinics, there are some community labs that do not allow that to be done. And then in this initial pilot, they mailed people their PrEP from home. Then the authors here collaborated with Emory CFAR and updated this study to do a sort of second phase in 2018, where they used a central lab that they had worked with and really ironed out those kinks to be able to get the self-collected samples done and resulted. They used microcapillary tubes, which are kind of small tubes that you can fill with finger stick blood for creatinine, HIV, a semi-quantitative RPR for syphilis, and then they used urine samples for gonorrhea and chlamydia. And they wrote up in 2021 in this paper that 46% of those people chose to use these kits and that there was improved extragenital gonorrhea chlamydia screening coverage. But when they used this trusted lab, for whatever reason, they saw that there was lower completion of the blood tests. So there was a little bit of a trade-off from going from this third-party lab to using a trusted partner. So even when you try to do that, it doesn't always work out perfectly. And then many of you here in Seattle are maybe very familiar with Kelly Ross, this model that was initiated a telehealth program in 2015, One Step PrEP. So in this model, pharmacists, again, lead this. They're doing adherence counseling and assisting with compliance for the medication for patients. And then they looked at sort of in this analysis follow-up, essentially 1 month and every 3 months thereafter in person. They were able to do point of care HIV testing there on site, which is again another option if you have that capability. And they also did creatinine. The rest of the labs were sent out to a third-party lab, molecular testing labs or MTL. They saw in this paper that 74% of people were able to start PrEP the same day. So that's a benefit of doing point of care testing right there on site. And then almost everyone is able to start PrEP with zero cost, which is something that we see in Washington State. Thankfully, we've got resources for that. They saw high adherence, and then the effective dropout rate was actually much lower than other programs have seen. So only 25% over about 3 years. So for the pharmacy-based model, what are the benefits and drawbacks? So similar structure as before. So, users can receive services where they're getting their medication, and there are some people who really prefer that. They want to go just to one place, they get their testing there on site, they can pick up their medication, and then they're done. They don't need to go anywhere else. They, have everything kind of in a one-stop shop. This also allows you to expand access for PrEP by, leveraging additional health workforce members. So not just relying only on, medical assistants, nurses, advanced practice providers, but also leveraging the number of other people that we have working in our pharmacies, which is a pretty big ecosystem for healthcare. This could be potentially impactful in rural or suburban settings where there may not be a lot of clinics for people to go to. And pharmacy staff, as we know, have expertise in sort of the insurance issues and how to get coverage for different costs. What are the drawbacks? So this may not be feasible in settings where there's not a state PrEP assistance program, which really, I think, was part of the success for the Kelly Ross program. And then I didn't mention this here, but both the Iowa program and also Kelly Ross here work because there is a state agreement where you can have basically collaborative kind of treatment agreements between a physician who oversees this program and then the pharmacists, so they can kind of work as independent kind of practitioners in the setting. But it does require, your state to have laws that permit this. So not every place has this CDTA. So if you don't have that, it may not work. There are some challenges with getting reimbursement for pharmacists, and if there are people on the line who know more about that, I'm interested to hear. This also can require additional pharmacist training. So if the pharmacists have not been trained to do phlebotomy, but they need to draw blood on site, they'll have to learn to do that. And I think pharmacists also aren't trained during their school and their residencies routinely to take sexual histories. And so if you're counseling people about how to have safer sex practices and adherence, that's something that they'll have to consider if you're making this sort of program. The other thing I think is important is not all pharmacies have the appropriate space and layout for people to actually do like a rectal swab collection or to give a urine sample. So if that's something that needs to be considered in sort of configuring the space for a PrEP clinic. And then, of course, as I mentioned, you need to have a medical partner to link someone to HIV care and to sort of oversee the ordering of all of these tests. Okay. I will now move on to the internet-based. I don't see any questions in the chat. Great. Okay. So internet-based PrEP models, there are several out there now, and I'll show you some examples of these. These are often not affiliated with a clinic, and they're often proprietary, where a person will go online, they say, I want to start on PrEP, and this company will send them a kit and then authorize lab orders, typically that they can take to like a LabCorp or a Quest to be fulfilled locally. There may or may not be a medical consult that's attached to this. Sometimes that's an additional cost for people. And some of these programs take insurance, but many of them will sort of tell you up front, you're paying for the service out of pocket. And there really can be a range of costs up to $500+ for some of these. So if you go in and you type in home STI testing into Google, there are a ton of options now. So you may recognize some of these companies. I know I've at least seen advertisements. I think Google knows that I think about sex and sexually transmitted infections all day. So like anytime I go to like look up something on Amazon, I get ads for things like this. So Everlywell, I think, is a popular one. Quest has a program, stdcheck.com. There are a lot of these options. I think these are maybe the three most prominent that I've seen. So Molecular Testing Labs in the top right, PlushCare has a program, and then Nurex also. So, these are more becoming prominent. Patients may ask about these, clients may say, why can't we use this? It's possible. I think you just have to make sure you know what you're getting and that there's a pipeline to be able to exchange information freely. I mean, people have to understand the limitations of what some of these programs are offering. CDC does have its own sort of home testing program. Kenneth Mayer talked about this at a prevention conference, and they're ramping up these tests that they're sending out to people. You can order these through the link that you see there. And I think I saw on both the NASTAD website and also CDC, they have direct links to these. So different options if you want to kind of look at it either from a commercial perspective or more public health perspective. So what are the benefits here of this internet-based model? So again, this is patient-driven. Oftentimes what we're seeing is, people go on and they sort of choose their own adventure, click all the things that they want to get tested, whether or not they need those tests. If they're going to pay for it, the lab will take the money gladly and they will run those tests. So it is pretty easy. It's convenient. There's potentially less stigma associated with this as people are able to kind of sit in their home. They don't even necessarily have to talk to a provider to be able to get, say, an HPV test run. This can be preferable, again, if the person doesn't want any contact with a provider or for their insurance company to be billed. They can just pay out of pocket. And this actually was pretty crucial during the height of the pandemic when clinics were stretched thin and there was not really much staffing to have people come in, or there were restrictions on who could be seen in person. This fulfilled a sort of pandemic need for STI testing. Remains to be seen sort of how much this will be, fulfilling that need as we're coming out of the pandemic now, thankfully going a little bit more to kind of normal operations. There are some drawbacks, again, maybe out of pocket, tests may not be appropriate. And what we have found with these often is these last three bullets are sort of important with some of these commercial direct-to-consumer programs is there may be limited assistance with result interpretation. So say, for instance, someone orders a syphilis test, they send off their blood sample, the test comes back positive. We have seen in some cases where the people are kind of left in the dark. They don't know what to do. What does this mean? Who do I call? Do I need to be treated? And, I think that's a major drawback. The other is sometimes there's a delay to treatment and follow-up. So the lab is ordering the test, they give you the result, but then they aren't necessarily giving you treatment for the gonorrhea that they diagnosed. They then refer you to go to a county clinic for that. So there could be, a long time in terms of a delay between when someone knows and when they actually are treated. And then there's no sort of law necessarily that says that people have to report those results to the jurisdiction where the patient lives. And so if the lab just reports it to the kind of headquarters in California where their company is from, I think they are technically in compliance, but that doesn't really help a person who's living in Renton for public health to kind of know what's going on and help assist them. So a lot of drawbacks to that. Feel free I can share a paper that we sort of put out to talk about a lot of these details if people are interested. So overall, these are the considerations that I have, I think, for a home-based PrEP model. So there are several operational kind of capacity barriers that we'll talk a little bit more about. Costs can be prohibitive. There's some specimen sample limitations. There is really no official guidance for this. This is kind of a new, although this has been happening, home-based collections for a while, there really isn't any specific guidance on this from any sort of body or set of guidelines. There can be some technical issues. So sort of ramp up of technical assistance might be needed for people who are getting this online. There is high interest and acceptability and an increasing need for this, I think, as people are really wanting convenient options. Is this cost effective? There are some studies that show it could be in terms of getting more people screened for gonorrhea and chlamydia at least. And this may increase testing uptake and frequency. So it remains to be seen on that, but I think there's certainly potential. So I want to focus just on a couple of these points here because I think they're really important when we're talking about implementing a program. So as I said, OraQuick is the only approved HIV home test. There aren't any for syphilis, for creatinine, or for gonorrhea or chlamydia. There are several point of care tests for these STIs, but these are not widely available. The platforms can be expensive. And so if your clinic is not doing, dozens and dozens of these, it may not be feasible for you to have these in your site. And again, that doesn't help you if the person is at home and you're in the clinic. There is this sort of allowance for gonorrhea and chlamydia sampling, at least, for people to kind of self-collect their samples within a clinical setting if they're under quote unquote medical oversight at a provider facility. And this has been something we've been doing for years and years, where we've proven that self-collecting samples will give sort of equivalent results in accuracy to a clinician collected sample. However, technically the FDA does not allow these samples to be self-collected from home and then run in a lab. So although this has been done for a long time, if people are concerned sort of about some of these kind of sticky areas of the regulatory world, that's something to consider. There is something called a laboratory derived test or a laboratory based test that can be done. And there's a modification that's, I don't want to say like a loophole, but a way that you can kind of get around that. But what they say is that if you're going to do this, number one, you have to validate the test yourself. So you have to compare the sensitivity, specificity, the test characteristics from a home collected sample versus a clinical specimen, and then make sure that those line up. And whoever the lab director is has to kind of sign off on that. And there's lots of ways that could be done. You could use leftover specimens from clinical samples, or you could set up a small kind of pilot study to do this. There's no specific protocol for it, and it really just depends on what your lab director wants. The other component is you need to provide accessible remote instruction. So giving people technical assistance for how to collect the sample if they need that. And then there also needs to be support for when the result comes in, how can people sort of get their results and then understand what those mean and what the next steps are. So because of those two limitations, I think this is a big reason why we are still where we are for home collection of specimens for STI testing. I was on a meeting just this past Friday with some representatives from CDC and NIH, and they said that there are ongoing discussions between those two organizations and also the FDA to try to expedite this process. And they know that this is a big barrier and people want this, they've been doing it. But the problem is that there isn't a company that is willing to kind of take this on, because they would have to basically verify that samples are able to be collected in the home, people won't drink the medium, the dog won't get into it, and then that the specimen is valid by the time it's shipped across the country and gets to the lab. It's not really hard necessarily to do, and we know that this could be done, but we just need someone to take that on and give those data to the FDA. So I think they're working on it, but until then, we're kind of in a hold pattern. And then there is this consideration as well for certain medical devices, whether they are approved and registered by the FDA or whether they have an investigational status for use. So I'll talk a little bit about that later. We're doing on time. Okay, doing all right. So this is a really busy slide. I just kind of put this together to more as a reference for people, and happy to send this out if anyone is interested, but this is sort of the menu of different options that you could have as you're kind of picking and choosing what you might want to do for your clinic. So for HIV, of course, there are lab-based tests. You can do point of care testing, although that's not recommended necessarily for PrEP. The OraQuick, excuse me, isn't, but point of care testing, if you have that available, yes. I've kind of put some dollar signs here to show you what the relative cost is of all of these, and then some additional considerations. And I think those are maybe the most important here. So for HIV, we don't really have an option at this point for viral load testing. And I think I saw Joanne was on, so maybe she can talk to us a little bit at the end about what's coming down the pipeline for sort of new diagnostics. For creatinine, we do have a point of care test. Of course, this can be done in the lab as well. And this may not be the most high priority if you're wanting to kind of do the bare bones of what's necessary for PrEP follow-up, although it is in the guidelines to do this every 6 to 12 months. If you have a low volume sample, it may not be possible. For syphilis, typically we're wanting to get an RPR, a titer, because most people, not most, I would say a high percentage of people have had syphilis before. And so you're not going to get just a treponemal test. You want to get an RPR to know if this is a new and active infection. And so you can't use dried blood spots for that because they have pretty poor sensitivity for the RPR. And then you have to keep in mind, the higher the titer is, the more volume of blood you need. So if you're only getting, a few drops in a little tube, that won't really be enough to tell you that the titer is, 1 to 64. For the treponemal test, of course, like I said, limited utility if people have had prior syphilis. And then for gonorrhea chlamydia tests, I think many places have looked at this, sending them in the Aptima medium, just sending it in the mail, and specimens do okay being mailed in. I think they're stable at room temperature for 30 days. And some people have even looked at, doing different temperature excursions and then doing the testing after that. And it seems to be pretty stable. So just a few considerations. Again, happy to provide this if people are interested. So before I move into talking about briefly about our study, I think this is kind of the 101. What are the steps, things to think about if you say, I want to do this? So number one, who's your target population going to be? You need to gauge interest and whether or not people would actually want to do this. So the way that we did that was with a survey, but there are obviously many ways that you could do this. You need to find a trusted lab partner. So is this going to be an in-house validation that needs to happen? Or is this a lab that already has this thing up and running and you could just kind of plug into their system that's already going? What lab tests will be offered and what samples are you going to use? Finger stick, dry blood spot? Are you going to use whole blood? What is the method that the samples will be collected? Who's going to order the test and who will follow any abnormal results? You need to have a system for that before it actually launches. Funding, of course, is important. Will you be billing insurance, or will PrEP be doing it? I think here in Washington State, you can use PrEP for lab testing, but I think depending on sort of the way that you are using these lab developed tests, that's a little bit more of a gray area, and you'd have to look into whether or not that's sort of permitted. There are, of course, staff resources and different duties. So a lot of roles to play and people that need to follow up on these programs, and then picking your telehealth platform. So whatever that is, Zoom, telephone, whatever. So I just wanted to put these resources here. The CDC does have a website that talks about telehealth for HIV prevention services. So feel free to look through that. And then if you have not seen the Washington University in St. Louis, in collaboration with Prime Health, has this really excellent teleprep hub that has different resources for everything you can think of, like how to bill for telehealth services, how to choose the platform, how to have patients collect their samples and send them in. There's everything you can ever want to know on there. So please do look through that. Okay, so right now I'm going to shift gears and just talk about our experience here in Public Health Seattle King County. No questions so far that you can see, Roxanne? I don't. Okay, great. Okay, so we talked about a lot of these structural barriers. I'm not going to belabor those, but I think the idea is that home-based services could meet some of these challenges. So it could increase testing, uptake, reduce barriers to persisting on PrEP, but it's important to kind of know whether patients will be able to do this and whether they want to do this. So when we were thinking about all of those considerations I showed you in the implementation slide, these are some things that were important for us to consider for our program. So the cost, convenience, we want direct results to be delivered to the patient. We want there to be some potential for rural reach in the future as we're sort of looking at scaling this up. And that also addresses this issue for the potential for health equity. We don't only want this to be available to people who are right in central Seattle and have access directly to our clinic anyway. Of course, we want results to be linked to public health in terms of reporting diagnoses. And then also we want guideline-based testing. So what that looks like more discreetly is extragenital gonorrhea chlamydia testing with NAT, having a telehealth option, 4th generation HIV, which is most commonly what we use for PrEP monitoring, and then tests that can differentiate acute syphilis. We want to avoid finger sticks because we've sort of found in our patients initially in this pilot I'll show you next that people weren't too keen on pricking their finger multiple times to do this. If people are interested, I can share some data that I think Lauren, I saw, was on the call, had found through some of the discrete choice experiment work she's doing that are interesting to think about in terms of what people will consider for how they collect their blood samples. And then we also wanted to minimize third-party lab involvement. So how this came about for us is, in 2019 and 2020, we were thinking about how can we get people's samples collected from home and sent in? And so we did choose one of those lab partners that I put up on that slide with lots of the different options, but there were significant delays. Sometimes results were taking up to 30 days to come back, which is not useful, I think, in clinical practice. And so we had to kind of think about another option. And so in 2019, we did a preliminary survey asking people in the sexual health clinic who were on PrEP whether or not they might be interested in collecting their own samples using this Tasso device that you see here. And most people said yes. So we said, okay, this is enough to kind of move forward with a pilot. So since the time that that pilot was done, and now this Tasso device has been classified as what the FDA calls a class 2 device. So it's essentially the same as a medical lancet, what you would use in a clinic to prick your finger for like a blood sugar check. So no special kind of registration or anything else needed to be able to use this. You can use it just like you would a regular lancet. So in our pilot study, we surveyed 166 people who were on PrEP and also people who were known to have syphilis or suspected to have syphilis, and then people with HIV who were seeking STI care either in the sexual health clinic or in Max Clinic. And then we offered people to participate in a self-sampling trial using the Tasso device. So there were 48 of those people. And then we did sort of what I described, which is kind of a validation study, essentially, where we collected the self-collected samples and then a clinician collected sample. And then we compared those to see if the results from those agreed. And we did see high agreement for both HIV, for syphilis, and for creatinine. And so we determined that it was feasible to do this. We did use 2 devices. Back when we did the pilot, we were using an earlier generation Tasso device that gave less volume, and now we're using a higher volume device. So it's a little bit better. But even then, 93% of people were able to collect enough sample to get their monitoring tests for PrEP. And this seemed to be pretty acceptable. 88% of people said that they were interested in this, and about half of people felt like it could increase their likelihood of staying on PrEP. So with that, we sort of moved forward into a randomized control trial with the aims that you see here. So we wanted to evaluate the impact of home-based PrEP on PrEP retention as sort of the primary outcome and figure out what the factors are that influence implementation. There is a plan to do some sort of cost analysis, looking at how much this will cost the system versus standard of care and whether there's any incremental value of this service. And then ideally thinking about scale up in the future of this intervention. So in March 2022, we began our initial enrollments, but then right after Mpox hit and things kind of fell apart, we were all really focused on that and research came to a halt. But then in December 2022, Kate, our amazing research coordinator for the study, came on. And since then we have done really well at enrolling people. We're at about 25% of target within just about 4 or 5 months, which is excellent. So I'll share with you some preliminary data from our study so far. So we've approached about 155 people and enrolled 100 people in our study. You can see the breakdown of who was in what group there. The median age is about 33. Male sex assigned at birth, 99% of people, about 7% are transgender, non-binary, or genderqueer, or two-spirit. You can see the race and ethnicity breakdown there. I was surprised when putting these together about how diverse I think this is compared to our clinic population that tends to be I would say primarily white, but usually that 38% is more like 50 to 55%. So I think that is a testament to sort of I guess I will say Kate's amazing work doing these enrollments here. So you can see annual income and the sexual orientation listed there. So in terms of our retention in PrEP care, on the left side, this is since the study initiated in March 2022. In the blue, the people who were in the control or standard care group. And in the peach, you can see the people who are in the intervention group who have the option to do home-based testing. And then the gray bar is overall. So for all takers, it's been about 80% for the PrEP retention at 4 months. But that's with a big caveat. There was a period of time there where people weren't really actively in the study per se. We weren't engaging with them because we were focused on mpox. So there was a little bit of a halt. So if you look at since the study relaunched, there are fewer numbers, of course, but the retention seems to be pretty high, but we're obviously very early. So that 4-month period, we're going to follow people through 18 months. So we have done pretty well in terms of getting people to do their baseline survey. That's where some of those demographics came from. But it's been quite a challenge to get the 4-month survey done. So we're thinking about how to improve that. So far, about 60% of people have opted for home sampling and about 30% of people to come into clinic to get their blood drawn and do their own swabs here in our sort of brick and mortar clinic. And the reason that we hear most for that is that people say, oh, I just live like 4 blocks away. I just walk in and do it. Like there's no need for me to send my sample in. So that's fair. But we know we do have people who live quite far from clinic who this might be a little more useful for. So far, we've had about 10 people since we kind of relaunched who have submitted their kits, and samples seem to be arriving, as expected within a couple of days of UPS pickup. We've had all but one that had adequate enough blood for testing. So we did resend them a kit for low volume. We've had a couple of lab challenges. So specifically with the creatinine with our partner at UW, sort of working that out a little bit, what those workflows are like. I think there's been some turnover of staff that sometimes when the specimens arrive, they're not aware of what they are or what they're supposed to do with them. And so we're working that out. We have no issues at all with the gonorrhea and chlamydia swabs. We did have one person that had a false positive HIV test, but then the confirmation was negative. So these are some additional analyses that are kind of planned moving forward, looking at satisfaction, PrEP adherence in the study, time to action on abnormal results, and what the STI positivity looks like in each group. And then we're going to be doing some qualitative work to look at barriers and facilitators as well for this project. Like, did it work? Did it not? And why? So what are our next steps for our study? So we're going to continue with sort of looking at this as a way to increase PrEP retention and figuring out what are the factors associated with implementation of this. But I think the second part has kind of shifted a little bit, where now we're thinking about whether we can collaborate with our neighboring county partners, specifically in Tacoma Pierce, using some work that Roxanne and others have led, doing a landscape analysis of PrEP services there, where we see that there's really limited access to providers, and they would appreciate having sort of more options for STI care there. So seeing if we can partner with them and then potentially Spokane County to get this intervention there and see if it works. So kind of summarizing here, I think this is a summary slide, I think, and also just future directions. So I think convenience is king, and people do want options to initiate and stay on PrEP and to receive STI screening. So this is this so-called differentiated service delivery, where not everyone needs the same thing. Maybe some people want different options that work for their lives. So I think teleprep or remote PrEP monitoring may be a way to improve uptake and retention, but we'll see as we follow people in the study. There's a lot of work that still needs to be done to identify and reach populations that could benefit from these services, and trying to find out who those people are and how to get this to them is a challenge. And we really, I think, need to take care to not promote inequity in doing this. So my hope for the near future, and discussing, as I mentioned, with CDC and NIH, is that we can get clearance for self-collected gonorrhea chlamydia specimens. I think this would really go a long way for allowing this to be scaled up into other jurisdictions. And I think, this could be really widely taken up across the country. So we do need advocacy for ongoing kind of support and, self-testing and point of care technologies. And I think some of that work is happening here at University of Washington, which is great. My question, and I don't know if we'll ever get to answer this in the next couple of years, is how might long-acting injectable PrEP fit into this? I think it's pretty complicated even when people are here in person. So could this dovetail somehow with remote PrEP monitoring? I don't know the answer to that. Probably not right now because of how much blood you need to do viral load testing and that sort of thing, but maybe this is a possibility for the future. So I will leave us on that note. Want to thank all of the people on this slide, especially the staff here at Public Health Seattle and King County Sexual Health Clinic, and all of the participants in our study. And that is it.
Thank you, Chase. That was excellent.